Hey, it's Scott. And we're still up here in Anchorage at their EMS symposium, and we're happily having coffee with Bob Pink. Again, an international expert when it comes to EKGs, capnography, and more recently, stethoscopy as well. So, if you're going to do a 12 lead on a kid, and we talked about before, and there's little differences, but at the end of the day, if you're looking at a 12 lead in a kid, except for these little variances, is there a huge difference that you're going to find in a little kid EKG versus the big people EKG?
One thing you're going to notice on kids is they have a very high voltage EKG. The V leads are going to be huge, and sometimes your machine will cut them off because they're so big. And that's because they have a very thin chest wall and the voltage is overwhelming. So whereas in adults, you might have learned that big complexes mean big heart, in a kid it doesn't mean that. And so there's no voltage criteria for hypertrophy in children. You know, you have to connect to the heart to see or take a chest X-ray to see how big the pattern is. So in kids, that's one thing you're going to see. Those being at 12 leads, you'll see the axis shift to the right in children because the heart's setting on the right side that way more than it is on the left in their children as well. Also, remember there are rate limits for different things with kids too. Like an adult, you know, above a certain amount, above 150, we start getting SVT. In a kid, you can't think that till it's above 200.
That's really because, again, we don't like big people. So, but that's a really big deal. Because we tell people that, you know, yes, you can do 12 lead, yes, you can do the fancy things that the book says. And if your heart rate's above 180, 220, whatever that be, and what we found is kids work a lot easier than you have 110 but walking with it.
Yeah.
Because if you're fast asleep, the heart rate's 190, you sleep with an IV, it's 210. Right. So it's probably not attack. You know, versus your fat sleep is 190, your sleep is 190, the sleep is 190. Mm-hmm. You know, sure, you can talk to pediatric cardiology, but in other words, it's probably SVT.
Yeah. Well, you know, it's what do they say for kids? Fast, slow, or none for rhythms. And so, but you're right about that because anytime there's pathology or a re-entry pathway that might be pathology, you're not going to change it. But if you do something exertional or settle down or speed up, then that's going to be science.
Right.
Because it's not pathology. It's what it does over there.
Makes sense.
Yeah.
Now, just to make sure, if you're doing a 12 lead on a baby or a kid, do they pretty much go in the same spots as they do with a big person?
Yeah, anatomically speaking, you are on the outside, but you're on the inside. So your external landmarks correspond to your internal anatomy. So on adults, you have them spaced out more. Kids are, of course, narrow chested, but you're almost right on top of it.
Right.
That's why they make the little infant electrodes that are really, really small. That way you can get to those spaces without laying the electrode on top of it. How do you do something like that?
Oh, it's the same spot. Yeah, as long as the thing within the same spot.
Well, high-risk infants have usually right-side issues when they're born. So in infants, the right-side EKG is an important thing to do too. And you know, a lot of neonatologists were having to do it now. Yeah, I was talking to one once, and they said any kid at risk that's born, they'll get a 12 lead in the first couple hours of their life.
I can absolutely believe that.
Oh, yeah. Yeah, and these are neonatologists saying they come out because kids at risk need to know. And so sometimes the electrical aspect of the heart would be the first thing to show the pathology because the infant can't tell you he's having trouble. You can look at them and see they're messed up, you see they're blue and everything, you have suspicion, you're still going to get that EKG.
Neophylatic pediatric cardiologist feel on.
Oh, yeah.
And that's to get in the echo and yes, to get in an x-ray, but like you said, this you can have in 30 seconds. Yeah. To at least give you an idea as to, you know what, this ain't right.
Oh, it's a piece, another piece of the puzzle. And so there's so many pieces to a kid's puzzle, we got to go find them all. As I tell people, you know, patient assessment is your superpower. You know, so you have to be the best you can at it. And what's a superpower do? Well, in Spider-Man, his superpower was he could sense anger. So his hair would stand up. Well, you know, you look at these kids, you see they look sick, but your hair's already standing up. But when you assess further, it really was sick, so maybe it's not. So the more you know, then the better decision you can make.
It's like the old TV model, the more you learn.
Yeah, the more there's a story.
The more you learn. Bob, thank you. As always, an absolute pleasure. And with that, thanks, y'all, and bye from Anchorage.